Welcome friends to another section on arterial localization of acute ischemic stroke. That's very important to understand because it's a very tough topic and we always become a Ronaldo. When we see a tough topic we keep it aside and we always catch hold of an easy topic. Okay, let's try to make this tough topic as an easy topic, right? First we'll look at the arteries which are supplying blood to the brain. The very first that we all know is the anterior cerebral artery. Anterior cerebral artery, also known as the ACA, as abbreviation as ACA, supplies the anterior part of the brain, right? Now when I look at the anterior cerebral artery, what all areas does it really supply? First area it supplies in the motor cortex is the medial most part that we have discussed earlier as a paracentral lobule. Okay. Second area it tries to supply is the supplementary motor area. The supplementary motor area. And the third area it supplies is the prefrontal area. Prefrontal area. So when I look at these three areas, I understand their functions also. Let us recall the functions of this area. If at all there is a problem in the paracentral lobule, what kind of deficit are we going to get? We get a deficit of a lower limb weakness, one. So we get a deficit of a lower limb weakness with urinary incontinence. If you remember, the motor cortex for the lower limb was the paracentral lobule, and an area in the brain to control the bladder was again the paracentral lobule. Supplementary motor area, what was important for assumption of a posture, yes, and often inhibition of the primitive reflexes. So in these patients, yes, we get a resurgence of primitive reflexes very often. Resurgence of primitive reflexes. So all that reflexes that I have tried to tell you about, especially the grasping, sucking, maybe the palmomeatal reflex, they're going to come back in them. And most important in our life that we always have a sense of social well-being maybe, and that is a prefrontal area, right? If there is a problem in the prefrontal area, we all understand, we get our patient an anti-social behavior to be seen. So behavioral abnormalities are very pathognomic as said for the frontal lobe lesions, and which artery is involved here is the anterior cerebral artery. So these are the few important clinical manifestations or deficit will occur if there is a damage in the ACA that we find. Okay. Now apart from this, do remember this concept that along with this there is going to be few more deficits that we get if there is an ACA infarction. One of the important one is the gait apraxia. Cannot walk as a term, yes, gait apraxia. Apraxia is a term that we already know, inability to do a task which we are already knowing in a sense of skillful task, right? So if I'm moving the lower limb, I'm moving it with the help of the paracentral lobule. Now what happens is that there is a lesion in the paracentral lobule, yes, because the ACA infarction has occurred. Because of that I'm unable to walk. So that's a very simple concept, gait apraxia. So this is another very important one-liner kind of a thing which is very often asked in all the exams. So that's about the ACA. But remember, do we find ACA infarct so very common? No. Now there's a reason behind this. For this, let's look into the anterior circulation. If you remember, the anterior circulation made up of two major artery, the internal carotid artery, which is a branch of the common carotid, right? So the ICA will come at the base of the brain, would bifurcate itself into an anterior cerebral artery, one, and the second one is the middle cerebral artery, two. So MCA, ACA are the two branches of the ICA that we find. But the blessing in disguise is this. Yes. So this is something that we find. The two AC are connected to each other with the help of a communicating artery. So this is known as a anterior communicating artery that we find, right? So ACOM is another abbreviation used very often for it, the anterior communicating artery. So there are two segments which I look at of the ACA. One is before the communicating artery, the other one is after the communicating artery. We can just label them and number this. This one has A1 and this one has A2 segment. So there are two segments of ACA that we usually find. The A1 segment, right? The A1 segment is actually the pre-communal segment. The communicating artery before that is a pre-communal segment, right? On the other spectrum, when I look at the A2, yes, this one happens to be the post-communal segment. The post-communal segment after the communicating artery, right? Now I'm telling this because based on them we find a particular deficit. So it's very clear in the diagram, as you can understand. There was a thrombus sitting in the A1 segment. It may be an embolus, thrombus, anything. It can be an ischemic, embolic stroke, thrombotic stroke, anything. Now if the blood doesn't come over here from this particular zone, don't worry, all is well. Blessing in disguise is an anterior communicating artery which is going to send the blood to this part, and now the reperfusion is going to happen. So it's very clear. If you get a pre-communal A1 segment infarct, we find actually no deficit. Or I can use the word in a simple way as a transient ischemic attack, even though ischemia will occur but no infarction because of good reperfusion, right? So remember this concept. The pre-communal A1 segment ACA infarcts are usually asymptomatic, or even if the symptoms happen, they happen to be classically reversible. What about the post-communal? Now if at all there is a thrombus sitting over here, this time even if the anterior communicating gives me the blood, it won't really help me out because there is no flow over here, right? So this time in a post-communal segment, A2 segment, yes, the deficit which I have told you above is going to happen. That means a contralateral lower limb weakness will happen, gait apraxia will happen, maybe the antisocial behavior will also happen. So the classical symptoms of an ACA infarct, whenever we find, it usually happens due to the post-communal or the A2 segment infarction, not the pre-communal or the A1 segment infarction. Okay, this thing is very clear that the anterior cerebral artery doesn't supply the entire cortex. So if I make the diagram of the homunculus again, yes, so we'll try to chart the coronal section of the primary motor cortex. Yes, the homunculus diagram. Now when I locate in this that the lower limb happened to be seen in the paracentral lobule, then came the trunk, arm, forearm, and then suddenly we had a very big hand and maybe the face laterally. Okay, so out of this diagram one thing is very clear, that the anterior cerebral artery supplies this part, right, and the middle cerebral artery supplies rest of the cortex. Okay, so the paracentral lobule is somewhere under the control of ACA, rest of the cortex is supplied by MCA. Now apart again from physiology, that there are cells which are located, okay, in the layer 5 of the brain. So when I locate them, they are the bed cells which are located in the layer number 5 of the primary motor cortex. So they give me an impulse to move the body in the form of a track which descends down, known as a corticospinal tract, right? Now this whole thing is going to come down as a signal, right? So if I locate, everything is going to get down like this in form of a track which is known as the corticospinal, also known as the word pyramidal track. So there are the cells in the brain which are known as a pyramidal cell, large cells of beds, you know, they are present somewhere in the layer 5. So they give origin to this tract, the corticospinal or the pyramidal tract. Now everything is going to converge below into this part. Yes, This small part is known as your internal capsule. The internal capsule. Right. Now when I look in the internal capsule, it has got various parts in it. One part which is here is known as the anterior limb of the internal capsule. The other part which is basically having all the corticospinal fibers over here, yes, this one is known as the posterior limb of the internal capsule. And between the two is a small bend that we saw, that's known as a genu. Now in this internal capsule, especially the posterior limb and maybe a part of genu, will find all the corticospinal tract fibers or the pyramidal tract fibers coming down. Now when I see the body in the internal capsule, I see the human body being represented like this. So in the genu part, the facial fibers are coming, the lower limb and the upper limb fibers are coming in the posterior limb part of the internal capsule like this. Okay. Now another very important information is this. So when I look at the posterior limb of internal capsule, is actually being supplied by an artery known as the MCA or the middle cerebral artery. So the MCA supplies the posterior limb of internal capsule where all the corticospinal fibers are sitting there, right? Now why I'm telling this story, because we should all know, we'll consider MCA separately now after this, but if at all there is a lesion, yes, if at all there is a lesion in the MCA territory in the posterior limb of internal capsule, that particular lesion is going to be very, very small. But if I look at the deficit, it's going to be big, because all the corticospinal fibers which are funneling like this, yes, at the point of convergence I've cut them, right? So when I look at the deficit, it's going to be a large deficit seen to me. So a small lesion with a large deficit happens in the artery involvement MCA at the level of internal capsule, especially in the posterior limb. Okay, this whole thing has got a name with it, been given as the dense hemiparesis. The dense hemiparesis. So find this out as a name, hemiparesis. Half side of the body is weak. Dense because fibers are together. So remember this old concept, whenever we use the word dense hemiparesis, we are considering the lesion at the level of internal capsule due to the involvement of the artery MCA. I'll talk about MCA separately, don't worry. But before that, few concepts of physiology and anatomy need to be revised. So if I want to draw this diagram again, I find that the corticospinal fibers are originating in the bed cell layer number 5 of the primary motor cortex, converging together at the posterior limb of internal capsule, right? So this one was the cortex above and this one is my internal capsule. But below that, remember, there is something which is holding the brain, known as the brain stem, right? And I look at the brain stem, there are 3 parts of it. The topmost layer is the midbrain, then the middle layer is the bridge pons, and the lowermost is the medulla. So if I want to draw those structures in a cut section, maybe a transverse view, I'll find the midbrain like this. Alright. After that we see the bridge, that's the pons, and finally below that is my butterfly shaped medulla. So all these are transverse sections of 3 parts of the midbrain that I look upon. First, the topmost layer is the midbrain. Between the two is a bridge, that's the pons, and the lowermost layer is my medulla. Now what do I find? That the corticospinal fibers, right, they're coming down and converging somewhere towards the anterior part of the midbrain. So if you remember, we've discussed this pigmented part in the movement disorder Parkinson, that's the substantia nigra. In front of it there's a connection of the midbrain with the cortex, right? So that particular connection has got a name as the crus cerebri, right? Finally all this is again going to come down till the level of pons, finally reaching medulla like this. So one thing which we understand out from this particular diagram, when the corticospinal pyramidal tract is descending downwards in the brainstem, it tries to converge itself medially, one, and always places itself anteriorly, right? Now at the lower part of medulla, all this is going to cross the midline, come down into the structure which I know as the spinal cord, right? Now approximately 85% of the fibers which are descending down of the corticospinal tract are going to cross the midline at the lowermost part of the medulla, okay? And now they come down in a structure spinal cord, right? Now when they come down, they again place themselves more laterally. So I'll make the exact diagram for you. So the placement again is somewhere not medial, it's more lateral this time, like this. So this tract now, which is a corticospinal which descends down in the spinal cord laterally, has got a name, and the name for this is the lateral corticospinal tract that we have, okay? Now everything is going to come down, stop at a gate, right, to become a perfect nerve for a muscle. And that particular gate which resides in the spinal cord is somewhere in the anterior horn of the gray matter of the spinal cord. So if I make a small gray matter inside, okay, so if I make a gray matter inside, somewhere in the anterior horn of the gray matter of the spinal cord, yes, we have our anterior horn cell sitting. Anterior horn cell is also known as a motor neuron, right? So AHC. And now finally everything is going to come out from there in form of a nerve to supply a perfect muscle like this. So this is how left side of the brain controls the right half of the body, because the descending corticospinal crossed the midline in the lower part of medulla, right? But what about the rest 15%? This thing you'll again pick up in your classes of anatomy, that these 15% are going to come down in the spinal cord in not the lateral but more often in the anterior part of it. So this is what is known as your anterior corticospinal tract, and this wala is again going to come down, cross the midline at the same level, in the sense that where it stops, it crosses the midline and then supplies the opposite half. So corticospinal, be it lateral, be it anterior, is going to supply the opposite half, okay, in the sense that the origin of the impulse is always from the contralateral side of the brain, okay. Now I've been using this word gate very often for anterior horn cell for the reason because I want to make this thing very clear to you guys that gates are always at the boundary wall. You know, it's not India Gate or Gateway of India, which is something middle, but this is all the gates that we have got are always at the boundary wall. So this anterior horn cell also becomes a kind of a boundary wall. For what? So I'll just make a small diagram over here to explain my concept. So all this thing has originated from the cortex, crossed the midline and come down in the spinal cord, stopped at a gate anterior horn cell to become a perfect nerve for a muscle, right? So our anterior horn cell behaves like a gate for two things, right? Remember this, anything above the anterior horn cell, which is anatomically and technically a corticospinal tract, is classified under the heading of an upper motor neuron or the UMN. Anything which lies in the anterior horn cell or maybe the nerve together is classified under one roof as your LMN. So there are two things that we understand. One is UMN, that is a corticospinal tract. Another one is the LMN, that is the anterior horn cell and the nerve together. Okay, so they form a team. That's why in clinical practice we often get two kinds of paralysis seen in any patient. First paralysis that I know is my upper motor neuron paralysis or the Ullmann paralysis. The second paralysis that I know is a lower motor neuron paralysis or the Ullmann paralysis. Now, what are the key differences between the weakness that we find as Ullmann and Ullmann? The first thing, the tone of the muscles that we get. Remember this, the tone of the muscle in a Ullmann paralysis often increases. So there is a stiffness or a spasticity phenomena seen in these patients. I hope you remember, we've discussed this in the movement disorder as well. Resistance to a passive movement is rigidity. One which keeps on increasing with movement, yes, that is spasticity. A unidirectional rigidity, spasticity, right? Ullmann on the other spectrum is just the opposite. The tone here has to decrease. In our patient, what do we get? Often flaccidity. So spasticity is Ullmann, flaccidity is always Ullmann, right? Then we have the reflexes to be checked, which are known as the deep tendon reflexes or the DTR. So what we do with a knee hammer, striking it deeply on a tendon, are known as the deep tendon reflexes, right? They are found to be brisk in a Ullmann paralysis, or hyperreflexia occurs here. While in Ullmann on the other spectrum, there is going to be hypo or areflexia seen. So two statements again. Hyperreflexia is a Ullmann sign. Okay. Areflexia or maybe hyporeflexia is an Ullmann sign. Okay. Apart from this, plantar. Plantar, I know you all must have done in your graduation somewhere on bedside clinical examination, and I know every student at least in neurology knows how to do a plantar, right? Because in my whole MBBS I only knew how to do a plantar. The moment I used to see a neuro patient, I used to go and touch his feet, take his Ashirwad, start doing the plantar. One of our patients was so bugged up by the maneuver, you know, every day we used to come near him, we used to offer his own key. And one happy Sunday, no one was there in the ward to look after him. I found he was checking his own plantar. Okay, so how do we do a plantar? In the plantar response, we strike the sole of the patient's feet from the heel, taking it laterally along the lateral border of the feet and till the ball of the big toe, rotating it in the interior part. So when I look at the plantar, which is a normal plantar, I find this. I take it from the heel along the lateral aspect of the sole of the feet like this. So this is a plantar which we find as a flexor plantar. A normal plantar is always a kind of a flexor plantar if you want to elicit it. Right? So this is a plantar response that we find. But the normal response that we get is this. Yes, this time the big toe goes up and all the small toes are going to fan out. So this one is an abnormal response, or they're known as an extensor plantar. Now remember this concept, that the plantar that we find in a Ullmann paralysis is often seen as an extensor plantar. Right? Now this extensor plantar is also known by another name as Bembinski sign positive. So if anyone asks you what is a word Bembinski positive meaning to be, it is an extensor plantar every time. So remember, the plantar which is extensor has got a name with it as Bembinski sign positive. Okay. While on the other spectrum in Ullmann, we are not worried about the plantar, but one thing happens quite frequently in them, atrophy or wasting. You know what the anterior horn cell gives it to the muscle, or the nerve gives it to the muscle. It actually doesn't give it only the contraction signal. it also gives and delivers a kind of a trophic factor. So in an anterior horn cell lesion or maybe a nerve lesion element, the trophic factors towards the muscle are not being delivered. Because of that, the muscle will undergo a lot of shrinkage, or what we know as wasting. So how do we look upon wasting? In a particular limb, when I compare it with the normal side, this would happen. So this may be the normal side and this is the abnormal side. In the abnormal side, you can see the muscle has shrunk. So atrophy and wasting is something which is very typical for a element kind of a lesion. I agree. Some of the students do tell me later on, sir, in UMN also I saw wasting. That will come quite late into the disease. So something which is early, maybe more characteristic for element, for maybe atrophy or wasting characteristically seen, is always an element paralysis. One more thing happens. In element paralysis, we often find in our patient fasciculations. Fasciculation to be defined as is a visible or a palpable muscle twitch. So visible or a palpable muscle twitch is defined as a word fasciculation. So I'll show this video to you. How does a fasciculation actually look like? It's somewhere like this. So you can see the thigh muscles especially, they're moving on their own. The movement which I can see twitching, the movement of the patient we can feel also twitching. This kind of a twitch is known as the word fasciculation. In a vernacular language, the patient will tell you this story. Doctor, the limb has totally shrunk. There is atrophy, wasting seen. But that muscles which are still there are moving on their own. So that movement on their own, visible and a palpable muscle twitch, is known as a fasciculation phenomena. Now do remember this, that fasciculation is something very characteristically seen when the lesion is at the level of anterior horn cell. So when we get a lesion somewhere sitting at the gate, anterior horn cell, we often get a fasciculation phenomena seen. So in a nutshell, this is something that we need to rewind about, the paralysis of two types, UMN and LMN. A bit more you will understand in your classes of physiology and anatomy into why is it happen, and maybe one or two extra points here. But I'll come back to my localization, the arterial localization of stroke. Here I'll talk about the middle cerebral artery. Now the very important artery to be discussed is my middle cerebral artery, or the MCA. Now when I look at the distribution of the MCA, I made a diagram earlier also in the homunculus. Yes, it kind of supplies most of the motor cortex except for the lower limb, which goes with the ACA. So I may draw another coronal view of this thing to explain it in a view. How deeper does it go to supply the brain? Okay. Okay. Now what we find over here, that the artery which we saw, the common carotid, right, would have come at the base of the brain, and somewhere in the subarachnoid space would have bifurcated itself into one artery which goes to the paracentral lobule, which is known as my ACA, or the anterior cerebral artery. We've discussed this one. Now another branch it tries to give, yes, is the middle cerebral artery, or the MCA. And now the MCA will divide itself into two divisions. One it goes above and other one which goes below. So somewhere in the anatomy you'll read a detailed version of this, like where does it divide, okay? But important thing in medicine is that what is something which is supplied by the MCA pre-division and post-division, right? So if I label this one as the middle cerebral artery, the entire middle cerebral artery, we label this as M1 division and the second one as the M2 division. So there are two divisions of MCA that we understand, one before division and one pre-division. One which has divided and gone above is known as a superior division. One which has come down here is my inferior division, right? So what do we find? What is the M1 supplying? Actually the M1 supplies and gives the arteries which supply the deeper structure in the brain. Yes, and those deeper structures are nothing but structures located somewhere in the basal ganglia. Maybe I can make a diagram of basal ganglia. Yes, one may be the thalamic part, right? The lentiform nucleus laterally. Okay, between the lentiform nucleus and thalamus, if you remember, we had something got sandwiched. Yes, the internal capsule or the IC. So there are branches which supply the structure deeper in the brain, especially the internal capsule part, which I'm more worried with because and that's actually the posterior limb, which is very important, having all the corticospinal information there. Okay, now the branches which are gone over here are known as the LS branches. LS stands for lenticulostriate, lenticulostriate branches. So lenticulostriate branches are supplying the internal capsule specifically. Okay, so which is a part of the middle cerebral artery, the M1 division. So that's a diagram which I want to take ahead, and I'll make all this thing again in a different view. So this one is the MCA, which has actually divided into two divisions, superior and the inferior division. The something which I found pre-division was giving branches like this. Okay, so the segment which is pre-division is known as the M1 segment, and the segment which was post-division is known as the M2 segment. Okay, the M2 segment happened to have two divisions over here. One is the superior division, second one is the inferior division. The superior division supplies the frontal lobe and another part, that is the superior parietal lobe. Superior parietal lobe. While on the other spectrum, the inferior division, when I look at, yes, it supplies the temporal lobe and the inferior parietal lobe. Inferior parietal lobe. Okay. Now let me talk about the proximal occlusion, that is M1 occlusion. So M1 has got the lenticulostriate branches which go and supply somewhere the internal capsule part. Okay. Now what we find here is that there has been an occlusion over here in the M1 branch of the MCA. Okay. So let me talk about the first occlusion, okay, of the M1 branch of the MCA. The M1 branch of the MCA. So what are the deficits which I am going to get? First deficit, remember this, the very first deficit. What is the MCA supplying? It is supplying the homunculus, most of the part of the motor cortex except for the lower limb. So my patient is going to have what? Contralateral hemiparesis. Now why contralateral? Because if it's a lesion in the cortex on the left, the right side of the body is going to go weak, because the corticospinal fibers, while descending down in medulla, the lower part, they cross the midline, right? Now there's a term hemiparesis and there was a term dense hemiparesis which we have read somewhere in the internal capsule. Okay, so I'm not writing dense because for dense hemiparesis there has to be a specific occlusion of these lenticulostriate branches. That means a small lesion is going to create a large deficit. But look at this lesion. It is not a small lesion. First of all, it's always going to be anatomically as well as radiologically a big lesion. So I'll not write the word dense, I'll just write the word hemiparesis. Now the common confusion which happens, sir, why are you writing hemiparesis? Sir, you should write for us upper limb weakness, because lower limb weakness won't happen, no, because that's supplied by ACA. Look at this. For a general chance like this, if I get an infarct in MCA like this, a big infarct, that will kill the fibers of the upper limb face, yes. But maybe around that big infarct, there is always an edema that will involve the lower limb fibers also. So when I want to differentiate this patient and see this patient out, in patients of contralateral hemiparesis, we will find in them weakness is more often seen in the upper limb than over the lower limb. So these patients have got a weakness which is more often seen in the upper limb than the lower limb part. Okay, remember this. So if it is upper limb and lower limb may be equal, then we call this as dense, because every fibers get affected here. But this time if I look at the upper limb, it has got a power of 3/5. Lower limb is still having a good power of 4/5. So that is what is known as hemiparesis. Now along with this, if I get a patient with hemiparesis, they are going to have a different style of walking, which we understand as a word gait. The gait that we find here is the circumduction gait. Now why is it known as circumduction? Let's try to find it out. So for example, I'm having weakness on the right side of my body, or right hemiparesis. I'll try to fold my arm like this and extend the leg like this, for the very reason because my body is seeing a spastic phenomena, because it's UMN. Now let me rewind this old fact again from physiology, that the upper limb is flexed and the lower limb is extended. That calls for a decorticate posturing. Why? Because the lesion is above the midbrain, right? So these are cortical lesions which are anatomically above the midbrain. So the upper limb will go flexed and the lower limb will always stand extended, right? Now we find, I'll take the support of the normal side. Okay, that is the left side of my leg is normal. I'll lift up the normal side on the hip, drag the foot on the floor, making all the time a half circle, circumduction. Now look at this movement again. I'm not able to flex my knee joint. Why? Because it's all spastic, it all extended. Okay, so we make a half circle for the reason because the distal half is more weak than the proximal. The upper limb is more weak than the lower limbs. So hardly any arm swing you can see. Okay, so let me put this on again, that in a UMN lesion that we found due to involvement of the corticospinal tract, okay, due to the involvement of the corticospinal tract, yes, we found in our patient the weakness that we found was found to be more distal than proximal, one, along with spasticity phenomena. Okay, so because of that, I always took the support of the normal side, dragged the foot. Why? Because distal foot is more weak than the hip joint. So because of that, I was able to walk making a half circle every time like a compass, known as a circumduction gait, right? Now do remember this spasticity. Let me play that video again. The spasticity phenomena is good for me, no? Because right side is weak, I keep it on the floor, I don't fall down even though it's weak. Because of spasticity, I can hold it on the floor and keep on moving further. So I find in my case, if I'm suffering with right hemiparesis and there is spasticity in the right lower leg, so I'll take the support now of the normal side and move the normal side ahead. So one thing which is very clear now, that spasticity may be beneficial in a corticospinal tract injury. Why? Spasticity is found to be beneficial in a corticospinal tract injury. Why? because it helps to maintain balance while walking. So it helps to maintain balance while walking. Okay, so my patient is walking with a circumduction gait, but in order to maintain balance so that the person doesn't fall down, even if they keep the weak side on the floor, spasticity is found to be helpful. So remember, if an MCA infarct occurs, then you have a contralateral hemiparesis and the patient will come with a typical gait known as a circumduction gait. So that's about the corticospinal fibers. Apart from this, these patients will also suffer with contralateral hemianesthesia. Why? Because this time, it's not only the frontal lobe being supplied by an MCA, it is also the parietal lobe. The sensory cortex gets involved in these patients. Because of that, I get hemianesthesia. Right? Apart from this, optic radiations are also involved, which are passing through the temporal parietal, no? So we get what? Contralateral heminopia. This we have discussed, that what will a parietal lobe lesion cause, what is the temporal lobe lesion cause, pie on the floor, pie on the sky and everything. So we'll find somewhere upper lower part, both of them are now gone because it's temporoparietal involvement of the optic radiation. So contralateral heminopia. I'll discuss detail about discussion in opthal also. Apart from this, these patients are going to have one more thing: ipsilateral gaze preference. Yes, I hope you remember this. Why did the ipsilateral gaze preference happen? We have discussed this in the frontal lobe. All this happens due to involvement of our frontal eye field. So if at all there is a lesion at the level of the frontal eye field, yes, then in that case the eyeballs are going to get deviated towards the lesion. So this is something common, not a difference between the left and the right side. So I'm just telling you, for any MCA occlusion, that is M1 before the division, these are four things maybe. Of course the gait also will be seen in MCA occlusion on any side, right or left. Okay. Now the difference will come in if at all there is a lesion on the left side or the right side. The difference is left or the right side. The left side is the dominant side. The right side is the non-dominant side. Okay, the non-dominant side. The dominant side, if at all is involved, we are going to have aphasia. That's very clear because Wernicke's Broca's area is sitting over there. So Wernicke's and Broca's both will be gone. I'll explain this concept. Why? Because superior division supplies the Broca's, the inferior division supplies the Wernicke's. So both of them are gone if at all the lesion is on the left side. So both of them gone, we'll have a global aphasia in the patient, global aphasia. And of course the left sided angular gyrus is also involved. So one thing extra, yes, TARS, okay, that Tare-Zamieper, Gerstmann syndrome, the Gerstmann syndrome that will happen in them. Now if at all the things are on the right side, do you think aphasia is going to happen? So I can write like this. One thing is very clear: aphasia will be totally missing in such people if the lesion is in the right MCA. But what else? If at all the right angular gyrus is involved, we have seen this thing, a lot of things will occur. Anosognosia. Patient denies, will have apraxia of 3 types. Yes, if you remember, cannot find the bed in the ward, known as the geographic apraxia. Oh, not the geographic agnosia, sorry, 2 types. One is dressing apraxia and the second one is a constructional apraxia. And then third, we'll have in these patients hemispatial neglect. Hemispatial neglect. So these are the three things that you'll come across if the lesion is in the right angular gyrus, because that's supplied by the MCA. Okay. So right to left confusion should not be there. Okay. So remember this topic, MCA involvement. But now let's look into the division involvement, superior and the inferior division. As I wrote earlier also, no, the superior division supplies the frontal, superior parietal, the inferior division supplies the temporal and the inferior parietal. Okay. Okay. So now we'll look into the involvement of the MCA, right? The superior division and the inferior division. So I'll write like this: superior above, right? Superior above and inferior below, inferior division. The superior division and the inferior division. Okay. Now we find this one, that which side is it actually supplying. So I'll label this as a left and the right. Okay, left and the right side. So the superior division of MCA, on the left side supplies the frontal lobe. If you remember, frontal lobe has got the Broca's area. So one thing will happen in these patients, Broca's aphasia. Okay. Inferior division on the left side supplies the temporal lobe. Temporal lobe has got the Wernicke's area. So my patient will have here Wernicke's aphasia. Okay. The superior division, right, on the left and the right side, both sides, you know, on both the sides, we have the parietal lobe also getting supplied by it, right? Parietal lobe, the superior parietal. If you remember, that was a sensory cortex for me. So be it left, be it right, on either side, okay, we're going to have few things common, again due to involvement of the superior division. One, it's the contralateral hemisensory loss. And of course, one thing added, of course, more important than this is the contralateral hemiparesis also. Why hemiparesis this time? Because superior division supplies the frontal lobe, the motor cortical part, okay, and a lot of it corticospinal origin also from the parietal cortex. We have discussed this in the cortical functions. So contralateral hemiparesis with hemisensory loss with Broca's aphasia, superior division. Contralateral hemisensory loss, contralateral hemiparesis with Wernicke's aphasia, it is the inferior division, right? So these are few facts that we need to remember. But remember, this is about the superior division I'm talking about. What about the inferior division? What does the inferior division supply? It supplies the temporal lobe and the inferior parietal. So first of all, make it very clear, in these patients, inferior division involvement, there is going to be absolutely no hemiparesis. That means they don't have any kind of a weakness. But one thing will happen, apart from right or left, wherever the lesion is sitting in, they will have involvement of the optic radiation that passes through the temporal and the inferior parietal. So these patients are going to have no weakness, one, but contralateral homonymous heminopia. Okay, contralateral homonymous heminopia. So please make this thing very, very clear in your minds, like left and right, there should not be any confusion. Left sided lesion will have aphasia, superior division Broca's, inferior division Wernicke's. Left or right, superior division, any side will have contralateral hemisensory loss with hemiparesis. while inferior division will not have any hemiparesis but will have heminopia with it. Okay, so these are the basics. Remember, any question that you'll find, you need to find certain keywords to explain the deficit. Okay, now remember this, that another very important artery is the posterior cerebral artery. It's another very favorite of all the examiners that I've seen. The posterior cerebral artery, or the PC. The posterior cerebral artery supplies the posterior part and the medial part of the brain. So let me put this in a diagram, that if I make a Ross section or a transverse section of the cortex, so I'll supply the posterior part as well as the medial part of the brain with the PCA. Okay, so let me mark out the medial part first. So on one side only I'm making. Okay, I'll make it on the other side for only one thing, this one. Okay, so when I look at these structures, what are they? This is the medial nucleus of the thalamus. This one is the medial nucleus of the thalamus. This one is the lateral nucleus of the thalamus. The lateral nucleus of the thalamus. Okay, then we have this part. Okay, the medial part of the temporal lobe sitting over here, which is known as my hippocampus. And then we have this part, which is the splenium part of corpus callosum. Splenium part of the corpus callosum. And then posteriorly when I look at, I'll have the calcarine area, which is nothing but your part of the occipital lobe. Okay, so let me chart out the deficit depending on the area involved. So when I look at the deficit, if at all there is a cortical lesion in the PCA territory, the medial nucleus of thalamus, remember, has something to do with the third nerve. We'll learn more in detail in opthal as well as in anatomy. So if the medial nucleus of thalamus is involved, there can be a third nerve palsy also. Apart from this, some behavioral abnormalities or hallucinations can also occur in them. So some behavioral abnormality, which is a function of the medial nucleus of thalamus, could be seen in them. Then the lateral nucleus of thalamus, that's the most important. That's the sensory gateway. So all the sensation are passing through it. So what we get here is hemisensory loss. Hippocampus, if you remember, was a gateway of memory. So all my working short term was converted into long term over here. So these patients are going to suffer with a memory loss this time. And if you remember, in aphasia also we have discussed splenium part of corpus callosum was involved. Yes, the pure word blindness will come in the patient. What is that? Alexia. Calcarine area, that is occipital part. Okay, they will have a visual field effect, put as a word as heminopsia. So these are the classical deficits which we find in a lesion, if at all, is involving the cortex and especially the posterior cerebral artery area. Now there are few syndromes in PCA that we need to remember about. Very important topic. I remember this syndrome known as a thalamic Jarine thalamic, gerain, Roussy syndrome. The thalamic Gerain-Roussy syndrome. What happens in these patients? Due to involvement of the posterior cerebral artery and thalamic part, the lateral thalamus, these patients suffer initially with hemisensory loss. The initial presentation is hemisensory loss seen in them, followed in that particular part by a deep agonizing pain. Deep agonizing pain. So this pain is very difficult to treat actually. So if a patient has come to me with PC involvement in the lateral nucleus of thalamus, they are going to have hemisensory loss, and on recovery they might have a deep agonizing pain over there. That's known as a thalamic Gerain-Roussy syndrome. Gerain-Roussy syndrome. Okay. Another syndrome that is very famous is the Anton syndrome. The Anton syndrome. In the Anton syndrome, we have a patient with cortical blindness. Okay, so my patient will have a cortical blindness, but on the other edge, this patient will be unaware of this and will often deny it also. So my patient will have a cortical blindness, will often be unaware of it and will deny it also. That's known as a typical Anton syndrome. Anton syndrome. Then comes in another very important syndrome to discuss. That's the Balint syndrome. Balint syndrome. Okay. I'll make it easy for you because there are few symptoms that we need to recollect and a mnemonic that will be very easy to remember. So let us wash out this topic with a soap. So soap is a mnemonic to remember the symptoms of the Balint syndrome that we have got. Now in Balint syndrome, the very first is S. S stands for simultagnosia. Now what do you mean by the word simultagnosia? That is, it's a kind of a problem in which the person has got inability to integrate the information from the center of vision with the peripheral information. So we'll write it and I'll explain you with examples. Simultagnosia basically means inability to integrate, okay, maybe the central information with peripheral field of vision. So while seeing something, like for example, the perfect example in Harrison they've given is this. So if I look at from a distance, this particular thing is a table lamp, right? But my patient will just see the base part of it and answer me it's an ashtray. Okay, so he cannot integrate everything. So there's a chandelier kind of a thing, there's a something to hold it, and then there is a base part. Okay, so he just looks at the base part and rest of the things he just cannot integrate together. So this is known as a simultagnosia. Maybe in the patient's life there's a lot of problems. So they if at all I ask my patient to read this and read all the A's, you know, this patient will read all the small A's, but the bigger A's he cannot read, because for looking at the bigger A's he need to integrate everything together. So that bigger A thing he cannot see, only the small A's he's going to see. So we often have this problem in our life. So all the big problems we often just neglect, and all the small problems we are just worried about it. Okay, so my patient cannot read a kind of a bigger A, because for looking at a bigger A he requires complete scanning of this visual field and needs to integrate everything together to make an kind of a A. This is what is known as the modified letter cancellation. It's given in Harrison. It's known as the modified letter cancellation. So my patient cannot actually look at a field of vision, in a sense that he is not able to judge this A, the bigger A's, because for that he need to integrate, no? He has to look from here to here and then again here to here and integrate this all together. So it's very difficult for him. But small things like, you know, table lamp he cannot see, but small things, ashtray, yes, he can see that one. Okay, modified letter cancellation. So the patient misses the larger A's and only remembers the small A's. Okay, maybe this. What is this? Is it A or E? This is E. So my patient will read this as E, 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 E. But what alphabet I have written with E is this A. So he cannot read the alphabet, but he can look at the smaller things and judge it very well. Maybe another image that I got from the books and the net is this. So he's a vegetarian and he'll look at everything around and he'll tell me these are all vegetables, mushroom and maybe a lot of vegetables over there. But it's a human being, it's a vegan man, you know, vegan man made like this. So he cannot tell me it's a man, okay? But he can look at the vegetables and name them perfectly. So smaller things he'll be able to judge very easily. But in a bigger picture, he cannot realize what is it. And this is somewhere explained in psychiatry also as this stealing the biscuits, okay? So, you know, there is a mother working, you know, she's cleaning the utensils, the water in the basin is overflowing, there are two kids who are trying to steal something from the cookie jar, and this boy is falling down. So I tell him to explain this picture. He tells me, yeah, there is a female who is washing utensils, yes, and he will just forget this one, that there's water already overflowing from the basin. He might tell me, look at this point, this boy is stealing this maybe the coconut jar, but is he falling down from a stool or not, he is not able to tell me. So maybe he'll tell every description of this picture in a small bites, not a complete picture, okay? Maybe naughty kids, you know, that will be a perfect example to explain this picture. Oh. So that's first thing that we find in the semantognosia patient in the balance syndrome. Second one is the O, okay, that is oculomotor apraxia. Oculomotor apraxia. Now the meaning of the word oculomotor apraxia is that it is a deficit in orderly visual scanning of the environment. So it is a problem or inability to visual scan the environment. For example, I'll show him a lot of trees together. I'll show him a lot of trees together. Okay, so he will just tell me, yeah, it's tree, he'll miss the forest for the tree, everything like this. So it is a part of semantognosia again, oculomotor apraxia. A stands for ataxia. That is your optic ataxia. It's inaccurate or maybe inability to reach a visual target, okay? So inability to manually reach a visual target. Inaccurate manual reaching of a visual target again. So there are a lot of things come in his field of vision, like you want to pick up a pen, he will see that pen, but manually when he tries to go there, he is not able to reach it properly. So this is known as the optic ataxia in the sense that he cannot concentrate on that point for a longer time. So he just fumbles somewhere in doing that activity. And what is P? P stands for the parietal lesions. Parietal lesions. Yes. Now the confusion happens, or why did you tell under PCA? Because most of the time in these patients, these are the dorsal parietal lesions, and they are somewhere located at the watershed zone between the MCA and the PCA. So please understand the small concept of watershed. So maybe the dorsal parietal lobe, yes, which is having a supply from MCA, also a supply a bit from PCA maybe. At the junction of the two, there is an infarction seen over here. So the watershed zone between the MCA and the PCA, and especially in the dorsal parietal region, is going to result in this balance syndrome. Okay, the oculomotor apraxia, the optic ataxia, semantognosia, and of course the mnemonic, remember, this is a SOAP. Now just to sum up aphasia also, like which kind of aphasia will occur in which artery involvement, we all know this. So let's find other 2-3 aphasias also. Right, so we had one area in the inferior frontal gyrus. This was my Broca's area, right, if you remember. Then area was there somewhere located in the inferior superior temporal gyrus, right, and this was my Wernicke's area, if you remember. And now what happens is that the MCA comes and it divides. So let me make the middle cerebral artery, it comes and divides. It divides into two parts. One, it comes as a superior division, one it goes as an inferior division, right? So if I want to mark this one, this is the superior division of MCA, this one is the inferior division of MCA, which supplies the Wernicke's and the Broca's area. And we know this Broca's aphasia, superior division of MCA left side, Wernicke's inferior division of MCA left side. Okay, so another very important catch here. There were two more areas that I told you in aphasia chapter, the sensory speech association area and the motor speech association area. Where are they sitting at? So when I locate these people, they're sitting here and here. So this one happens to be my motor speech association area. The motor speech association area. This one is the sensory speech association area. Sensory speech association area. Now who all are supplying them? The motor speech association area is being supplied by the artery anterior cerebral artery, ACA, while the sensory speech association area is being supplied by the posterior cerebral artery of the PCA. So maybe with a different coloring scheme I can just mark it out. So if I remember, the ACA supplies the brain like this as a strip, right? So this one is the ACA. Okay. While the PCA, when I look at, it was comfortably sitting over here. So this one is the PCA. Okay. And rest all you know is MCA, right? Now I'm telling this because we got now the transcortical aphasias with us. Transcortical aphasia with us. Yes. The transcortical aphasia, which I know as the motor transcortical aphasia. Transcortical aphasia that I know as the motor transcortical aphasia. The motor one, which has got intact repetition, if you remember, but symptoms similar to Broca's. Sensory was having intact repetition but symptoms similar to Wernicke's. Motor speech transcortical aphasia occurs due to lesion in ACA. Sensory wala happens due to lesion in PCA. Wernicke's and Broca's, MCA. Okay, so remember this. Now let's move into the treatment part of stroke. Very, very, very important. Maybe for many years we have seen so many questions coming on it, but it's a very simple topic. The treatment part of stroke. Of course, that I'm talking about is the acute ischemic stroke. Yes. The first thing that is highlighted everywhere is to break the thrombus in the vessel by giving a drug, thrombolytic agent. Now when I look at the thrombolytic agent anytime, we got with us recombinant TPA, recombinant tissue plasminogen activator, or the RTPA that we know as. Okay, recombinant tissue plasminogen activator that we give to these patients usually is a LT place drug that we use. You'll read in Pharmac about it. But remember this, the dose is very important from my end. The dose that we use is 0.9 mg per kg of body weight. Okay. And maybe if you remember the maximum dose, that's also good. The maximum dose of using this drug is somewhere taken as 90 mg. So not beyond 90 mg for anyone you need to give this drug. Some of the studies done somewhere in Japan and maybe China side, they have used 0.6 mg also. But we follow the Americans, not the Japanese and the Chinese. So we'll go with the American and the Indian dosing schedule, that is 0.9 mg per kg. Okay. Now, whenever you use this drug, the ideal route of administration, the ideal route of administration is considered to be the intravenous route, IV route. Okay. Although there are studies done on intra-arterial also, but in India, especially nowadays, we often resort to the IV route of infusion. Now, whenever you use the IV, you give it the drug 10% as bolus, and rest of the 90% of the drug would go in as an infusion. Now the infusion has to go in for a duration of 1 hour time. So we have to give it slowly, not rapidly. 10% bolus, 90% infusion over the next 1 hour time. But who is the ideal candidate of this drug? You should know this one. Indication, first of all. When to use and may not to use, maybe. Indication part. First of all, there has to be a clinical diagnosis of stroke being made. You cannot just give it to any normal person, okay? And of course, once you have clinically diagnosed this patient, the patient would have come to you in less than equal to 4.5 hours of onset. Not more than that, okay? Now what happens is the meaning of the word onset. Onset means that the person was found maybe in a sense that, you know, he himself complained of the symptom. That is one thing which I know subjective as onset. If at all the patient was alone at home and no one was there around him and he could not call anyone around him and no one could see him, then in that case the onset is taken as, so one onset definition is when the patient complains of symptoms. Yes, something I remember this as an old thing, like, you know, in journal literature, and to educate the people about symptoms of stroke, we always tell them an acronym to remember the symptoms of stroke, so that any patient who has got stroke should come early on time. Now the acronym is FAST. F-A-S-T. Yes, F stands for the first, facial asymmetry. That means my patient has got some kind of a facial deviation. Then I think he has got stroke. Arm weakness. So the patient has got difficulty in moving the hand upper arm, upper limb completely, that's again considered as a very important symptom of stroke. S stands for the speech disturbance. So that means they have got some kind of a problem like slurring of speech, cannot understand, cannot speak. And the last important thing that we remember in the acronym is the time part. Because if they come to me within 4.5 hours of onset, I'll use the Brahmastra recombinant TPA to recanalize the vessel very well. So to educate the people, the layman, even in the hospital, this is a very simple acronym to remember it, known as a FAST one. Remember, approximately 85% of stroke patients, especially the ischemic stroke I am talking about, they've got hemiparesis. So 80% of stroke patients have got one symptom with them, 85% sorry, hemiparesis. Okay, so hemiparesis in the sense means not only the lower limb, the upper limb is weak and more weaker than the lower limb. That's why we are considering the arm weakness at this point. And remember this, it's a very simple logical thing, like infarcts are more common in which artery? Is it ACA, MCA or PCA? Of course it's going to be the MCA. So middle cerebellar infarction is more common than anything else. Because ACA you already saw, no, pre-communal, post-communal. So there can be a lot of communal angle over there. Okay. Now, another thing in the onset part is this. When the patient was last seen normal. Another thing of onset that I know, when the patient was last seen normal. So like patient was alone at home, no one was there with him, he could not call anyone, no one saw him, what happened? So we consider the onset was when he's last seen normal. And another condition is this, if at all my patient awakens with a kind of a neurological deficit, remember this, if my patient has got up with a neurological deficit, okay, like means the patient slept and morning he got up at 6 a.m. and he found that his facial asymmetry, arm weakness, slurring of speech, everything was there, then in that case remember the onset is taken as when the patient went off to sleep. So in these conditions we usually find like the person has developed the stroke during sleep. Since the patient was sleeping, he could not realize it, no one was seeing him while sleeping, so no one would find it. So very simple concept. So the definition of onset of stroke should be very, very clear. Okay. Now apart from this, of course, one thing as an indication that I consider for thrombolysis is that there should not be any hemorrhage. It should not be a hemorrhagic stroke, otherwise it's going to be a disaster. And one thing which Harrison has given, and we need to understand that thing also, that the MCA edema should be less than 1/3 of the territory of the MCA supplying the brain. Okay. Now I repeat, most common infarcts are MCA infarcts. Okay. Now MCA edema is less than 1/3 the territory. Now what do you mean by this? The MCA edema is less, not very good or not very high. So if there was a larger MCA infarct, there had been a larger edema. So what do you understand through this? So if I make a section of the brain on one side and I find the ACA supplies this part, the PCA supplies this part, and the rest wala is the MCA. So it's like a cake we cut into 3 parts, no? ACA, PCA, MCA. Now I found in my patient there was an MCA infarction, and this particular MCA infarction was very large. So I found in my patient there was an MCA infarction and it was a very large infarction. Big one, really a big one, involving a large area. And I went and thrombolized this patient. The hell broke on that patient that day. For the reason, if I thrombolize a very big infarct, there are higher chances of hemorrhagic transformation. What do you mean by the word hemorrhagic transformation? Like there was an infarct and I gave a drug, Brahmastra, recombinant TPA. So instead of reperfusion, it caused hyperperfusion. Hyperperfusion can cause hemorrhage. So we use the word as reperfusion hemorrhage for them. So let me write this down. In an MC infarct, more than 1/3 the territory, because you know they have a larger risk of hemorrhagic transformation. So use this word very carefully. There's a hemorrhage which has come because of the drug. That's why we're using the word transformation over here. So this is something very important nowadays. In a ischemic stroke patient, if at all they come to me, I ideally get an CT and MRI done to find the MCA artery ischemia, infarction and the edema, of course. Because if it is more than 1/3 the territory, I'm not going to go and thrombolyze such patient. And of course the age of the patient should be more than 18 years, because most of the trials that we have done are for people above 18, not less than 18. So it's a right to vote, maybe right to drive also, okay, which comes as an indication for thrombolytic agent. Now most important is this contraindication when not to use the drug. For a journal example like this, when not to use the drug. Firstly, if my patient has got a sustained blood pressure above 185 by 110 millimeter of mercury, in spite of antihypertensive therapy. So in my patient, I've given an antihypertensive therapy, and in spite of that my patient is having such a high BP, then in that case I should not go and thrombolyze this patient. Why? Again the same story. The risk of hemorrhagic transformation will be very, very high in them. So the BP has to be below this level, then only I can go and thrombolyze the patient. Okay. Another quick contraindication is if the patient is having any kind of a bleeding diathesis in the background. Yes, that can be low platelet thrombocytopenia, can be high prothrombin like in patients of CLD and all. So bleeding diathesis, something like that, again if you give this Brahmastra, he's going to bleed. Okay. Maybe if the person has suffered with a kind of a recent hemorrhagic stroke or maybe head injury even, in that case we don't thrombolyze these patients, again because hemorrhagic stroke in the recent past has occurred. Some of the authors take it as 3 months, that's fine, but on an ideal note we should not consider for thrombolysis in a patient who had a past history of a hemorrhagic stroke, because we don't know, somewhere there was a vessel which has bled and has not completely healed, and on the other edge I gave a recombinant TPA, is going to again bleed to death. Head injury also, the brain has started healing, there's a gliotic changes there. You thrombolyze these patients, they're going to bleed on that old injury site. So the problem with these patients, that again the same old story of hemorrhagic transformation. Another one is a major GI bleed 21 days prior. For the reason, because if at all there was a GI bleed, there has to be some ulceration. GI ulcers take 21 days or 3 weeks to heal up. And if I thrombolyze my patient before that, he's going to again bleed from the old site. Major OT has been done. Okay. A major surgery has been done in the patient 14 days prior. So what happened now was that my patient has got operated from subabdominal surgery and all, and I thrombolyze him because he had a ischemic stroke. Internal sutures will start bleeding if I thrombolyze him before, maybe in that 14 days time post-operatively. Okay, so need to be very careful. Another thing is that which Harrison has removed but we still consider is the rapidly improving symptoms. Why? Because a patient had hemiparesis and is totally becoming normal now is a case of TIA, and he may not show even infarction on the MRI he might show some ischemic changes, that's it. So these are the contraindications that we need to look upon if at all we are giving a recombinant TPA therapy, the indication and the contraindication part. Okay. Then another drug, which we consider if the patient has come out of window period to be given is our aspirin. Aspirin is an antiplatelet agent and it will benefit the patient to prevent recurrent thrombus formation in the vessel, okay, and should be given, okay, as early as possible, maybe within the first 48 hours of onset. That's a better way. So studies being done, a lot of trials are there. I don't want to name them and confuse you. Just remember this, within 48 hours of onset you should start giving aspirin. Now the dosage part is something which bothers you. The dose of aspirin that they've been advised for to be given for a ischemic stroke is somewhere between 50 to 325 mg per day. Now the practical problem comes in, if I use the ecosprin or the aspirin tablet, the strength is 75 or maybe 150 and 325 goes till Disprin. So ideally we give 75 or 150 mg of ecosprin tablet or aspirin tablet to the patient. Third thing, maybe a double-edged sword that we carry with us is the anticoagulants. If you remember the anticoagulants, which we know, first one is our heparin or maybe enoxaparin, the low molecular weight heparin, right? Now when the patient goes home, we want to put him on some oral agent. We usually place them on a warfarin therapy. Warfarin therapy. But the problem is that, as I use the word, it's a double-edged sword. Double-edged sword in the sense that it is going to make the blood thin because it will inhibit the clotting factors, but the thinning of the blood may go to such an extent that there may be a spontaneous hemorrhage, a non-traumatic hemorrhage, very common in them. So you need to be very careful in using the anticoagulant agent. As far as stroke patients are concerned, we recommend these drugs often in two conditions. One, if they're suffering with atrial fibrillation, then we give it. Second, if they're having a prosthetic wall, then we give it. For the very clear reason, in AF and in a prosthetic wall, there is a higher chance of a clot formation inside the heart. Yes. So we have studied this somewhere in the etiology part of stroke, that there can be a thrombus formation in the left ventricle, atrium, or maybe on the wall surface. Now I'm not talking about bacterial endocarditis. This time I'm just telling you about the word prosthetic wall, an artificial wall which has come over here. On the surface of the artificial wall, a thrombus formation can occur, and by the push of AF or without AF also it can go to the brain. Or even if the AF occurs, the left atrial appendage could dilate. At a corner of the dilated segment, we might see a thrombus formation, again it will go to the brain. So we should know this, that these are the two clear indications for giving a kind of an anticoagulant therapy in a patient of stroke. That means if a patient of stroke comes to me with AF, I anticoagulate them. If they have a background history of a prosthetic wall being replaced with them, then again I give it. If you remember this in cardiology, that in patients of AF and in prosthetic valve, we usually anticoagulate them for the reason because they might have a stroke later on, right? Remember this concept. And there are a lot of things that we'll cover in cardiology, like the CHAD2V2 scoring and all that, okay? When to give exactly. So apart from this, there are other things that we need to know about. The aspirin, the thrombolytic agent, the anticoagulant, and now the number 4, neuroprotection. Neuroprotection. In the neuroprotection, to some extent they have done a study that hypothermia could be protective. Hypothermia was found to be protective for the brain cells, but we lack studies. And remember, to maintain hypothermia, you have to keep the person under a cold environment that will increase the secretions everywhere, and there is a higher risk of pneumonitis. There's a higher risk of pneumonia in such people. Okay, so we still don't recommend very often as a hypothermic approach to deal with the neuroprotection there. Okay, then maybe something for neuronal regeneration. In a journal care we can write it here. Is a constrained movement therapy. Constrained movement therapy. Remember this, in the constrained movement therapy, we immobilize the normal side of the patient. So if I'm suffering with the right hemiparesis, I'll immobilize my left side. So firstly, in these patients we immobilize the normal side. Okay, and we make the person walk from the abnormal side. And how will it help us? It will help in basically recruiting the unused neurons on the abnormal side. Okay, and in the long run they've seen that it is going to decrease the weakness on the abnormal side of the patient. So that's known as a term constrained movement therapy. Okay, so these are few things that we need to know about in management of stroke. But one thing should be very clear: TIA, the younger brother of stroke, when will he become stroke? Okay, for this we have got a very important scoring system to know about. Scoring system for TIA patients. So transient ischemic attack patients are basically scored on the basis of a scoring system. The name of that score is ABCD2 score. Now what is the meaning of the word ABCD and why it's D2 now? Okay, let's start with the first A, that stands for the age. Okay, the second B in the ABCD stands for the blood pressure. C over here stands for the clinical symptoms. Clinical symptoms. D over here stands for diabetes. Okay, before that, more important D, that is the duration part. Now depending on these five things that we take for scoring, we allot a particular score to our patient. If at all the patient who has come to me with TIA has got an age above 60 years, then these patients get a +1 score, +1 score. Okay, if at all in our patient systolic blood pressure, I can use the word or, either of the two. Diastolic blood pressure, if the systolic blood pressure is found to be above 140 and the diastolic has been found to be above 90, either of the two or both of them together, then we get a +1 score again. Clinical symptoms. Yes, in the clinical symptom, my patient has got weakness, or if at all my patient has got speech deficit only. That's it, without weakness. It can happen. If my patient has got a weakness, then that patient gets a +2 score. If my patient has got a speech deficit only, he gets a +1 score. With diabetes, we get a +1 score. If the duration of the whole thing was above 60 minutes or between 10 to 59 minutes. If it is above 60 minutes, we get a +2 score. If it is 10 to 59 minutes, we get a +1 score. So depending on the scoring, we can assess a patient, will he become a case of stroke or not? Okay, because remember this, TIA becoming a stroke is risk, if I look at, is around 10 to 15%, okay, in the first 1 month, or sorry, first 3 months. So what is the clinical application, like how much score, how much prediction and all this, all memory based thing. I will recommend you not to go into that much area because it's very difficult to remember. Just at your level, I think so, if you remember the components of ABCD, 2, it's sufficient, it's good. Okay, and remember one more thing. If I look at the risk of TIA becoming stroke is 10 to 15% in the first 3 months of TIA, and of course the highest risk when I look at is somewhere in the first 2 days. So in the first 2 days, the highest risk is always there for it. Okay, the ABCD2 score. Just one more thing I want to add upon. For this, I'll take you back into your notes. Okay, I'll write it here. That if at all, I want to give a treatment for a patient with carotid atherosclerosis. Yes, carotid atherosclerosis. If you remember this as a concept, we have discussed somewhere in the etiology part of stroke. If I want to give a treatment like carotid atherosclerosis, which can be a surgical therapy like doing an endarterectomy, okay. Remember this, if I look at a patient who is asymptomatic for carotid atherosclerosis, what are the chances of that patient getting symptomatic or for having a stroke? So there are 2 kinds of atherosclerosis, carotid. Okay, one is asymptomatic and other one is the symptomatic. Remember this, that the asymptomatic carotid atherosclerosis, the risk of stroke is very low, 2% per year. While the symptomatic atherosclerosis, if I look at, in the sense they had a TIA and all that, the risk is almost 13% per year. Yes, so very common, you find TIA patients and you find a carotid atherosclerosis, that means they were symptomatic and the chances of having stroke is almost 13% per year. So endarterectomy has to be done for them. Yes, if at all, there's indication for endarterectomy again. If at all the stenosis in this carotid atherosclerosis is found to be more than 70%, then only we do it. So the cutoff, we take it as 70%. Okay, so if you find a patient coming to you with symptoms like giddiness, that's it, only thing that they might come with, and you go back into the history, they had some arm weakness which recovered very fast, you advise for a carotid maybe a Doppler, and you will find that if the stenosis is more than 70%, go and do a endarterectomy surgery onto them, right? That's always a better way. Otherwise they will have a stroke and the chance of 13% per year. Okay, so that's all about the ischemic stroke, localization, maybe the etiology, and of course very important thing, treatment. Now see you again in the hemorrhagic stroke module.